Welcome to the deep dive. You're here to get up to speed on important topics quickly, and that's what we do.
That's the plan.
Today, we're focusing on something quite specific, Monteggia's fracture, a particular forearm injury.
Mm.
Think of this as your high-yield summary. We've gone through the sources to pull out the key stuff you need to know.
Yeah, we're aiming to give you the essentials, what it is, the causes, risks, treatment, the whole picture, really.
Our mission, basically, is to make understanding Monteggia's fracture efficient and effective for you. No fluff.
Exactly. Cut straight to the chase.
All right, let's dive in. First things first. What exactly is a Monteggia's fracture?
Okay, so in simple terms, it's an injury to your forearm, and it always involves two specific things happening together.
Two things.
First, you've got a break, a fracture in the ulna. That's one of the two long bones in the forearm, the one on the pinky side.
Right, the ulna.
And second, the head of the other forearm bone, the radius.
Yeah.
Well, its head, up near the elbow, gets dislocated. It pops out of its normal joint position.
Ah, okay. So, broken ulna and a dislocated radial head at the elbow. That's the combo.
That's the absolute key combo. That's Monteggia's.
Got it. Now, I remember there's a classification system for this, isn't there? Different types.
Yes, exactly. There are four main types, and they're based on which direction the radial head dislocates. It helps guide treatment.
Okay, walk us through them.
So type idle, that's the most common, actually involves the ulna fracture, and the radial head dislocates anteriorly towards the front.
Anteriorly, type 1.
Type 2 is an ulna fracture, but this time the radial head goes posteriorly towards the back, or sometimes posterolaterally back into the side.
Okay, type 2, posterior.
Then type 3. Here, the ulna fracture is usually a bit closer to the elbow joint in what we call the metaphysis, the wider bit, and the radial head dislocates laterally, so out to the side, or sometimes anterolaterally.
Lateral dislocation, type 3, near the elbow.
Right. And finally, type 4. This one's a bit different because you actually have fractures in both the radius and the ulna, plus an anterior dislocation of the radial head, like in type 1.
Wow, okay, so both bones broken in type 4. That visual you mentioned from Jane Agnes probably helps sort these out.
It really does. Seeing the different directions makes it clearer.
So 4 types, all about where that radial head ends up. How does someone get this kind of injury in the first place? What's the usual mechanism, the etiology?
Well, there are two main ways it typically happens. One is a direct blow straight onto the forearm.
Like getting hit with something.
Exactly. Or maybe more commonly, it happens from a fall, specifically falling onto an outstretched hand, but with the elbow extended straight and the forearm pronated.
Pronated, so palm facing down.
Yes, palm down. That specific type of fall puts the forces through the arm in just the right way to cause both injuries, the ulna break, and the radial head dislocation.
Right, that classic foosh injury, fallen outstretched hand, but with that pronation. Are there particular people or activities where this is more common, the risk factors?
Definitely. Things like high-impact sports, think rugby, football, maybe some extreme sports, contact sports in general.
Makes sense. More chances for falls and direct hits.
Exactly. And really, any situation that increases your risk of falling or any kind of significant trauma to the forearm or elbow area can potentially lead to it.
Okay, so let's dig into what's happening biologically, the pathophysiology. We know the ulna breaks and the radial head dislocates.
Right. And delving a bit deeper, that ulna fracture typically happens in the proximal the third closest to the elbow, or sometimes the middle third of the bone.
Okay.
And the radial head dislocation, as we saw with the types, is usually anteriorly or laterally. The big consequence of this is instability.
Instability aware.
In both the forearm itself, because the ulna provides a lot of the structural integrity, and crucially in the elbow joint, because the radial head is no longer properly articulating, the whole mechanism is disrupted.
Right, throws the whole elbow and forearm mechanics off. Now, if someone comes in with forearm pain and maybe a deformity, what else might be going on? What are the differentials?
Good question. You always have to consider other things. It could be a different type of forearm fracture, maybe just the ulna or just the radius without the radial head dislocation.
Okay.
Or you could have an isolated radial head dislocation, which is rare but possible, without an ulna fracture. And then, of course, simple elbow dislocations where the main joint is out, but maybe not involving that specific ulna fracture pattern.
So you really need to look for that specific pairing ulnar fracture plus radial head dislocation.
Precisely. That's the hallmark.
And how common is this injury overall, epidemiology-wise?
It's actually considered relatively uncommon compared to, say, wrist fractures or other common breaks.
Sure.
Significant when it happens, but not something you see every single day in most places.
Good to know. So what would make you suspect it clinically? What are the key features when someone presents?
Well, the patient will usually report acute, pretty severe pain right after the injury, focused on the forearm and elbow area.
Intense pain right away.
Yes. And swelling is usually quite prominent in that area, too. When you examine them, you might see an obvious deformity of the forearm.
Like it looks bent or angled wrong?
Potentially, yes.
Hmm.
And movement at the elbow will likely be very limited and painful because of the joint disruption and the fracture. If you gently press along the ulna bone, they'll have point tenderness over the fracture site.
Okay.
And sometimes, depending on the type and how displaced it is, you might actually feel the dislocated radial head as a lump or bump, usually on the outer or front aspect of the elbow, where it shouldn't be.
Wow, you might actually feel it out of place. That sounds pretty clear-cut.
Yeah.
How do you confirm the diagnosis then? What investigations?
X-ray is the absolute mainstay. You need good quality X-rays of the radius and ulna.
Just the fracture area?
No, crucially, you need to include both the wrist joint and the elbow joint in the pictures. This is vital to fully assess the injury and rule out any associated issues.
Right, get the whole picture. What views?
Standard views are the AP, anterior posterior, so front to back, and a lateral view from the side. Sometimes oblique views, taken at an angle, can be helpful if the standard views aren't perfectly clear about the radial head position.
Okay, AP and lateral, full forearm, including both joints. Any other scans needed?
Usually X-rays are enough for the diagnosis. But in more complex cases, maybe if the fracture pattern is unusual or there's a strong suspicion of significant ligament damage around the elbow, then a CT scan or possibly an MRI might be ordered to get more detail.
CT or MRI for complex cases.
You got it.
So, once it's diagnosed, how is it managed? Let's focus on the UK approach mentioned in our source.
Okay, so in the UK, for adults with a Monteggia's fracture, the treatment is usually surgical.
Surgery is the main route for adults.
Generally, yes.
Yes.
The standard procedure involves what's called open reduction and internal fixation, ORIF, for the ulna fracture.
Open reduction.
Yeah, that means the surgeon makes an incision, exposes the broken ulna, physically puts the pieces back together in the right alignment, that's the reduction part, and then fixes them internally, usually with a metal plate and screws.
Okay, plate and screws for the ulna. What about the radial head?
The dislocated radial head also needs to be put back in place. That's called reduction. Sometimes it pops back in once the ulna is fixed and stable. Other times the surgeon needs to manually guide it back. Then it needs to be stabilized to make sure it stays there.
How is it stabilized?
That can depend. Sometimes fixing the ulna provides enough stability. Other times, if there's ligament damage, those might need repair, or temporary pins might even be used. After the surgery, the arm is immobilized.
In a cast.
Usually, yes.
Yeah.
A cast or sometimes a splint for a period while the initial healing happens.
And I assume rehab follows.
Oh, absolutely critical. Post-operative rehabilitation is essential. A structured physio program to gradually restore range of motion, strength, and function in the elbow and forearm.
Now, you mentioned adults usually need surgery. Is it different for kids?
Yes, there's often a difference. In pediatric cases, non-operative management is frequently successful. This involves closed reduction, manipulating the bones back into place without surgery, and then immobilizing in a cast. Kids' bones heal differently and have more remodeling potential.
Ah, interesting. So closed reduction and casting might work for kids?
Often, yes. But even then, sometimes surgery is needed if the reduction isn't stable. And in some complex adult or pediatric cases, as I mentioned, you might need additional procedures like repairing torn ligaments around the elbow.
Right. So after all that, what's the general outlook? The prognosis?
It really varies. It depends quite a bit on the specific type of Monteggia fracture. Type A generally does better than, say, type 4. The severity of the initial injury, the patient's age, their overall health, and crucially, how well they stick to the treatment and rehab plan, all play a role.
So multiple factors.
Yeah, but the good news is that with prompt, appropriate management, whether surgical or non-surgical, and good rehab, the functional outcome is generally good for most people.
That's positive. But are there potential downsides? Things that can go wrong? Complications?
Yes. Like any significant fracture and joint injury, there are potential complications. For the ulnar fracture itself, it might not heal correctly, that's called malunion, or it might fail to heal altogether, which is non-union.
Okay, healing problems.
You can also get persistent instability in the elbow joint if the radial head doesn't stay reduced or ligaments don't heal well. Stiffness is another big one, limited range of motion in the elbow or forearm rotation.
Stiffness, yeah, I can see that happening.
Nerve injury is a known risk. Specifically, the posterior interosseous nerve, which runs near the radial head, can be stretched or damaged either by the initial injury or sometimes during surgery. That can affect muscle function in the hand and wrist.
Ooh, nerve damage is serious.
It can be. Vascular injuries, while less common, are also possible. And then long-term, there's the risk of chronic pain and developing post-traumatic arthritis in the elbow joint down the line.
Arthrognathus later on.
Yes. So if complications do happen, they can unfortunately lead to long-term impairment of how the arm works. But it's important to stress that careful management, monitoring, and rehab are all designed to minimize these risks as much as possible.
Okay, good to be aware of those risks. Now, this is quite a bit to remember the types, the mechanism, the treatment. Any tips for locking this in? Mnemonics or memory aids?
Definitely. For the 4 types based on radial head dislocation direction, a useful mnemonic is all people love lateral angles.
Okay, break that down.
A for anterior, type I, P for posterior, posterolateral, type 2, L for lateral anterolateral, type 3, and the second A for all, meaning both radius and ulna fractures, type IV, which also has an anterior dislocation.
All people love lateral angles. I like it. Anything else?
To remember the 2 core components of the injury, just think U are okay. U for ulna fracture, R for radial head dislocation.
You are okay. Simple and effective.
And for the common mechanism, just visualize that pronated fall falling onto the outstretched arm, palm down.
Great tips. How about we try applying this with a couple of quick example questions?
Sure. Let's say a patient presents with forearm pain after falling onto their outstretched pronated arm. The X-ray confirms an ulnar fracture and shows the radial head is dislocated anteriorly. What type of Monteggia's fracture is this?
Okay, ulnar fracture, anterior radial head dislocation. That's A in our mnemonic, so type I.
Exactly, type I Monteggia's fracture. See how connecting the mechanism, the findings, and the classification works?
Yeah, that makes sense. Okay, another one.
How about this? What's the primary surgical approach for treating a Monteggia's fracture in an adult patient?
Right, we talked about this. For adults, it's usually surgery involving fixing the ulna and putting the radial head back. So open reduction and internal fixation, the ORF of the ulna, plus reduction and stabilization of the radial head.
Perfect. That covers the key surgical principles. The main thing really is just drilling down that core concept. Monteggia's equals ulna fracture plus radial head dislocation. If you remember that pairing, the rest starts to fall into place.
Absolutely. So, to wrap up, the big takeaway is Monteggia's fracture isn't just a broken bone, it's that specific combination injury. We've covered the types, causes, diagnosis, treatment, and potential issues. Hopefully this deep dive has given you a solid, efficient grasp of it.
That was the goal, to give you the high-yield points you need without getting bogged down.
And remember, if you're revising for exams like the MSRA or just want to solidify your knowledge, resources like passamatare.com and freemsra.com are great places to go.
Definitely worth checking out.
Finally, something to mull over. Considering how interconnected the bones and joints are in Monteggia's, what other injuries that might seem like just a single bone break could actually be hiding significant problems for joint stability or function elsewhere? Food for thought.
A really important point. Thanks for joining us for this deep dive.
Thanks for listening.